Good afternoon and welcome to COVID-19 Update, Stories and Lessons from the Front Lines of IT, a Health System CIO Media Inc. production sponsored by Imprivata. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of Health System CIO, and I will be your moderator today. We do have some interactive features we want you to take advantage of. You can send in your questions and comments in the Q&A box as they occur to you. We'll take them later in the program. We are going to have a little audience poll later we'd like you to engage with, and you can download the deck using the URL on your screen, and it'll be sent out in the chat box. Just so you see how we're going to spend our time today, we have a nice panel today. We're going to go about 35-40 minutes with the main panel, and then we're going to have our audience Q&A. Today we've got Kathy Ross, CIO at Broward Health, Chuck Podesta, Interim CIO at UConn Health, and Sri Bharadwaj, Senior Director and CISO with UCI Health, and Wes Wright, CTO with Imprivata. So we got a lot to talk about, and we have a number of wonderful panelists, so we're going to jump right in. Kathy, let's start with you. Can you give me an overview of your organization and your role?
Sure. My name's Kathy Ross. I'm the Chief Information Officer at Broward Health System, one of the 10th largest health systems in the United States. We have about 1,600 beds, approximately 60,000 admissions a year, 300,000 ER visits, and over 200,000 outpatient visits per year. We are situated down in the beautiful Fort Lauderdale.
All right, very good, Kathy. Thank you for that. Chuck?
Hi, Anthony. Thank you. Thanks, everyone, for taking time out of your busy schedules. Again, I'm Chuck Podesta. I'm the Interim CIO of UConn Health. We're situated in Hartford, Connecticut, and I've been here, actually only been here since January 31st. So I've gotten thrown into the whole COVID-19 project, if you want to call it that, right off the bat. So hopefully be able to talk to you about that from a beginner's perspective. Retired from UCI last October, University of California, Irvine Health, and I was telling these folks on the panel that I was looking to maybe move into the vendor world, but decided to take this interim position and wouldn't have missed it for the world. This is just a once-in-a-lifetime event from an IT perspective, although sad in many respects, but it's a time for us to shine. So UConn Health is an academic medical center. We also have a school of medicine, a large school of dentistry, and a clinical research as well. And I'll stop right there.
Very good, Chuck. Thank you. Sri?
UC Irvine Health. Thanks, Anthony, for your nice introduction here. UC Irvine Health is based out of Southern California, 5 minutes away from Disneyland. Patients who get to Disneyland have an event at Disneyland, typically land up in our hospital, 450-bed hospital down about just off the 5 freeway for those who understand and know Southern California. A large academic medical center connected to the University of California medical centers, UCLA Health, UCSD, UCSF, and UC Davis Health. And part of the product group allows us to do a lot more from a California perspective, understand what's going on in California. In addition to that, UC Irvine, which is our educational campus, where we are tied to with several thousand students who are part of that model, and who we've been able to understand what's going on from a academic side too. So a lot of learning, a lot of feedback for today.
Very good. Thank you. Wes?
Hey, morning, Anthony. Morning for me, afternoon for others, I guess. Name's Wes Wright. I'm the Chief Technology Officer at Imprivata, the beloved One Sign company. About 2,200 healthcare customers out there. We're branching out from that tap and go that into the digital identity management with some of our newer products like identity governance. Like Chuck, I was in the provider organizations for about 25 years, and then actually did make the decision to join the vendor community a couple of years ago when I moved over to be the CTO at Imprivata. And again, like Chuck, I wouldn't have missed this experience for the world. Imprivata is a great company.
Very good. Excellent. All right. First main question. Chuck, let's start with you. How hard has COVID-19 hit your community, where your health system is, and your health system?
Yeah, we're right at the beginning of the surge, Anthony. Based on our location, if you guys know Hartford, Connecticut, we're actually midway between New York City and Boston, which are two hotspots. And so those dots are starting to connect now at Hartford. So we're behind New York and Boston from the standpoint of a surge, but it started last Friday. We went from a small amount of COVID patients to doubling almost every single day since then. Our death rates are up as well. Unfortunately, that's whole part of the issue as well. So luckily, we did have some time to prepare while New York City was in reactive mode, and Boston as well. We saw what was going on there, knew what was going to come up in Hartford County, so we had time to get moving, and I know we'll talk about some things there, but we're about a week into it. It looks like from the data models that our peak will be sometime in early May, maybe even into the second week in May, so we still have a ways to go.
Very good. Sri?
We were up to the forefront of getting to understand what was happening. California was one of the larger states to be impacted, and Orange County initially had quite a few cases, while LA kind of stood out after San Francisco. So several initiatives to understand how do we help move this forward for us. Earlier on in the middle of March, we actually published a request for how we are actually combating the virus situation with the Orange County community. And there are two things that we started doing. One is accelerating research. We had a team of UCI researchers working on a therapeutic study, drug study backed by National Institute of Health. And this is, something what we thought, and I think the nation thought, was the first clinical trial that has possible efficacy, which should be, and we're hoping that we can get the patients looped into that one. And then we started in a big way integrative health, where you're bringing wellness through integration. Now, wellness, keeping your hands clean and 6 feet apart kind of discussion. We become part of that process, and that's something that we move forward pretty quickly down that effort. That's been our initial foray. Apart from getting into we'll talk a little bit more about the virtual care process as well.
All right, very good. Wes, what's been your experience dealing with customers? I mean, you've got customers all over the country. Some are in hotspots, some aren't. So what's that experience been like? Are you almost, putting out fires here and there and helping folks in that way?
You're right, Anthony. Most of our customers, they love us, but they don't want to see us. they don't want us on site, and which is totally understandable. So we've had to adjust how we do things, and that is, a lot of our technology, especially our remote access technology, our one sign technology, the tap and go stuff to where you don't have to mess with the keyboard. It's a little bit essential to some of the workflows that happen. So we still have to keep up with deployments and that kind of thing. And matter of fact, we gave away or are giving away free remote access licenses until right now. It's until the end of July. I could probably see that bumping out, depending, as Chuck was saying, the peaks are coming a little later than what we thought that they were going to. So I could see that bumping out. So we've really had to adjust to doing a lot more remote, where we used to go on site and make those personal connections and be able to whiteboard in person. So there's that one, and two, we have had some requests for product enhancements and that kind of thing. That before it would be, we wanted here's the product, and this this request plus this request plus this request, that's 100% what we want to, what the product wants to be. And now, instead of this request and then waiting to get this one in and waiting to get this one in, we're all about getting out that minimum viable product, and not letting perfect become the enemy of good, so that we can help our healthcare customers deal with this COVID crisis.
Yeah, so I think we'll talk about that, some of that go, a mentality and attitude that's required right now. Kathy, you want to tell us a little bit about what's happening down by you?
Yes, hi. Down in Broward, South Florida, it's one of the hard-hit areas as well. We, in the Tri-County area between Dade, West Palm Beach, and Broward, we really makes up the largest amount of COVID patients in all of Florida. We have really changed the world, and how we deliver care. And COVID has really caused us to rethink everything. I think one of the things that this challenge has brought is nothing's off the table anymore. I think it has really opened up the thinking of the healthcare in general on how we can deliver care and how we can meet the needs of our community. I think that is one of the things that we'll be discussing later, but how can we still take care of our community when we're on lockdown and everyone has this fear that they're going to be getting something worse if they actually get health care right now?
Yep. Really good point. All right, next question. Sri, let's start with you. What are some of the main things IT has done to support the health system's response? And some of the things we've been hearing about: telehealth, telecommuting for staff that can do that, reporting and analytics for analyzing the situation and understanding what's going on. Sri, you want to jump in?
Yeah, so I think every institution has done some of this in some way, shape, or form. Telecommuting is the norm, right? This is not, we had done telecommuting before, so this is not new. It's just that everybody telecommuting at the same time was something that we had not thought through. But we had the technologies, tools, capabilities to make it work. That was not the issue. The telecommuting for IT was fine, but telecommuting across for the organization itself was something new. That is something that we had not contemplated. So, of course, the rush to buy laptops and iPads and everything else had to happen. The rush to, also provide, ability for video visits for physicians, buying the cameras and putting the cameras in and getting them working as quickly as possible, start generating video visits. Those were some of the things that we did. The one thing which, stands out is communication. Our need for us to update our community, on the other hand side, the broader aspect of students from the UCI campus perspective was an important factor too. We had to keep the website updated. We had to have various people correlate the stuff and put it all together while we were all in some way, shape, or form telecommuting. That was an important thing that we found to be a big factor in helping calming some of the people's ideas and thoughts about how we do this right. The second big thing is how are we focused on our employees? A lot of our employees obviously are in the front lines dealing with patients with COVID, dealing with several of these challenges on a day-to-day basis. How do we keep them calm? How do we help them through this process? Not just provide a technology that will work, but making sure that they are supported, not just helping them through with the right PPEs, sourcing masks. These are the kind of things that really help us become a better, stronger healthcare environment. And I think that is what we focused on outside of the typical standard telecommuting and telehealth stuff. The one thing which we definitely did was reporting. We had to do that for our leadership to understand what was going on. We run Epic. Obviously, Epic released quite a few COVID-19 updates, and that was very useful for us to use those reporting dashboards and similar data generation and distribution mechanisms for our leadership.
All right, very good. Wes, when you're, in addition to the things that customers are doing with your stuff, I mean, a lot of these folks personally from all your time on the provider side. So I'd imagine those conversations are going a little deeper. Maybe they get into, here's all the stuff we're doing. What are you hearing as far as maybe the main things that CIOs are trying to get their arms around right now?
Yeah, it's coming in a couple of different waves, Anthony. Right there at the beginning, when lockdown first started happening, most of the CIOs, CTOs, my peers that are out there that still communicate with me despite me being on the vendor side, they were neck deep in building out capability. Whether it was a drive-through COVID testing tent, or we're using this conference room, or those beds that we had closed down for more potential bed space. So they were neck deep in trying to get new locations up and running. And once that little wave passed and they kind of could breathe, and it's still there a little bit, building out a new location is a lot harder than most people think it is. So you put up a tent. Well, when you put up a tent, and then you have to give connectivity to that tent, and then you have to put some devices in that tent. And then, logically, in your EHR, you have to build locations and workflows for that tent, and so on and so forth. So that took 2-3 weeks for that wave to pass. And now we're seeing people be able to lift their heads up a little bit and breathe. And what their absolute main number one focus right now is stability. Because while a doctor's or a clinician is in a patient room, gowned up, masked up, that's the last time you want to have your EHR access have something go wrong with it. So it's all about stability right now. Now that we've got the build out done, it's all about stability.
Very good. Kathy?
Honestly, we have done everything that the group has already discussed, but it has been in an expeditious fashion. Telehealth is something that my organization was just barely touching their toe in, and now it's rolled out everywhere. And it's not just your typical physician to their patients remotely. Now we have telepresence from the ED to the tents, from the COVID patients in the room that's in isolations. We have iPads so that the consulting physicians don't have to go in, so we can reduce our equipment. We have our ambulatory physicians who were really kind of resistant to virtual visits. Now their offices are closed down and they're only doing virtual visits to try to help. And this has really changed how we are delivering care in the entire community. And I think this is going to be something that is really causing creativity where it was always before resisted. As far as telecommuting to work, IT had always in my organization been able to work from home, but not everybody at once. And then we sent home approximately 1,500 people in 3 days. And we had to stand that up, create a mechanism for our employees to get into their devices and have the bandwidth in 3 days. I mean, this is things that if you'd have asked us, 4 months ago, can you make this happen by next week? Everybody in the entire country would have probably said, no, we can't do it. We didn't have the option of saying, no, we can't do it. We had to do it or close our doors, and we did it. We created videos for training. We increased our service desk to help with hands-on support. And now the outcome of that is that my organization is really looking post-COVID-19 at having a large remote virtual workforce because of the productivity level.
It's changing everything. Yep.
It's changing everything. And analytics, I think this is another area where my organization has moved 100% to a data-driven organization. We early on started creating a dashboard that pulled in multiple bits of information from numerous sources so that we know how many ventilators we have. We know how many PPEs we have per site. We know how many PIU patients we have, how many we have that are potential going to be needed in ICU with predictions. I mean, every meeting is based off that dashboard that we're constantly tweaking. I think this has elevated IT in the minds of everyone.
Mm-hmm.
And
I'll bet. Well said, Kathy. Thank you. Chuck?
Yeah, no, it's very similar to what Sri and Kathy just talked about. March is just a blur. I can't even remember from one day to the next what we were doing because it was the same, same thing, 1,500 people to work from home, set up virtual meetings. We had to drive through tent to do telehealth. We stood up in 72 hours, which would have been years at this organization. But it's just amazing to see what can happen to an organization when everybody's working towards one common goal. We did the same thing with iPads. That's been amazing. And even we've used in the ICU for compassionate care with the patient and their families. Unfortunately, we've had some incidents where, the patients are kind of being given last rites and families are not in the area. They're certainly not visiting, but sometimes they're in other states. And when this is going on, and so they've been able to talk to their loved ones, or at least their loved ones to talk to them at the very end. So when you see something like that, it's like, wow, this is really amazing, the impact of IT and just what an iPad can do to a particular family. It's just amazing. We're focused now on the analytics as well, but also on the surge prep because we are in the middle of that now. We're adding 230 beds to the organization. We had FEMA come in last Monday. Get out of the way when they come in with the National Guard. They are amazing. They just go. They cleaned out a couple of floors in one day. They started in the morning. They were done by the end of the day. And we've got 2 units stood up in like 3 days with all the equipment in there and ready to go. We're well on our way to getting the 230 beds open. Hopefully we don't need them, but they'll be there. On the analytics side, we're following a lot of IHME. That's the UW work that was done with Microsoft, Chris Murray. Awesome job. The whole peak, it seems to be moving. I think a lot of that's because of social distancing is actually working. It's, the number of admissions across the country have kind of flattened out a little bit, but the peak has also moved as well. So there's still the potential for a surge there. There's another one called COVID-19 Case Mapper, just opened up from Google and Stanford. That one gets down to the zip code level. That one's really interesting for us because Fairview County and New Haven County near New York tends to skew Connecticut counts because it's so close to New York City. We're a little further away, so having zip code level data is a lot better for us. But all in all, very, very similar to what everybody else is doing.
Very good. All right, next question. Another area people talk about is speeding up the change management process. And can it even be called a process anymore, or is it now just go, go, go? Chuck, you mentioned that before we jumped on the line today. So that's really governance, right? Change management. Well, are those the same things in your mind, change management and governance? And where is it now? And are we losing anything by not having sort of that formal governance? Are things sliding through that wouldn't? Is that okay? Are we going to have to clean things up down the road that may have gone through or been done a little bit quicker than we wanted? Wes, let me start with you. What are your thoughts around that?
Yeah, well, your first question is governance and change management the same? No, I don't think of them as the same. The governance is what I kind of use to determine my priorities and what I should buy and what I shouldn't buy. And my change management folks were pretty much all my techno geeks that we all sat around the table and said, okay, if I change this, is your applications and stuff going to be okay? So the big difference to me in my head. You know, as we discussed a little earlier on the call before we went live, no, actually we were live. We've really started taking on an MVP, minimum viable product kind of focus, instead of building out 80% or 90, 100% of a capability. Hey, we're chunking it up, and we're going to give you 20% right now, because 20% of something is better than 0% of nothing. And so we've taken on that mindset, and I think that's kind of that MVP mindset is setting in healthcare too. Yeah, I can't make it to where this technology is completely seamless to you, clinician. But you know what? I can give you this technology so that you can get this task done, and you might have to fiddle with it a little more than I'd like to. And then I'll take some time later down the road to get to that 100% for you. But for now, here, this will help you get your job done.
Kathy?
Well, I think for my shop, it has been modified. Change management and governance have been modified. It hasn't been thrown away, but one of the things that has been a positive is the fact that my team and the change management process are more engaged and focused and have daily calls about what is necessary and make sure that we don't cause unintentional harm with something that we're doing. So I think we're actually doing better focused change management discussions. And the same is happening with governance. We are so connected with the businesses, with the clinicians, with the CEOs, that we're making rapid decisions on what we will do and what we will not do, and what can be done and what can't be done. And we're delivering on that need quickly. So the business owners, the clinicians are aware that if we don't make this decision, it's not going to go forward. We're not doing anything without having the business owners at the table, and it's happening extremely fast. And we're making changes multiple times a day. We're adding new COVID requirements into our EMR every day. We're putting new capabilities in from a technical side standpoint every day. And the businesses are 100% aware of what we're doing, which has never happened.
It's amazing. Chuck?
Yeah, it's very similar. We've taken the approach of 80% fast versus 100% slow. And I think in the past, the way governance has worked has been really that 100% slow. You know, even in change management, you want everything to be perfect before you move something from test to production. We're not doing that anymore. We're 80% there, it's moving. We'll clean it up later. What we're finding is that the providers, even normally, they would see a problem and, right away be screaming at IT. And now they're much more patient around that, because they know that these things, as Kathy said, they're very connected to what IT is doing, and they understand the iterative processes we're taking, and they're working with us. And they're very much a partner and I'm hoping that continues in the future. From a governance perspective, my governance committee is the command center right now, and they meet. We have a virtual call every single morning at 9 o'clock, and so things are changing on a daily, hourly basis, and that's our governance committee right now. There is no monthly or quarterly committee; it's a daily committee, and it's amazing what you can get done. And it'll just be interesting to see how much of this post-COVID, from a structural standpoint, governance and change management, how much of that changes as well.
Definitely. Sri?
When I look at governance, I mean, you're looking at input and output and some ways to means to manage that, right? If I have an input to or a request that I need to make and I have to deliver an output within 4 hours, the governance is embedded into the process in a way, right? That's what's happened to us. I mean, we there's nothing called the business and IT anymore. It's us coming together and saying, what information can we get from our EMR and deliver that information to the physician in order for him to make a better determination of that specific case. That's been the model, right? You don't go around in circles trying to figure out how are you going to do it. You just figure out. I'll give you an example. Surge planning, right? Our incident command center, Hicks, picks it up and run with it. We identify how are we going to get that done. We work with Epic, pull the data together, understand their COVID-19, a cookbook that they put together fairly quickly, and we are delivering a solution within days for managing that process. That is a classic example of if you are going to be doing surge planning is like almost bringing a brand new module of activity into the system. It could take months. It's being delivered in days. So there is governance right through the various stages, and in many respects, the output may not have been matched what the input had really wanted. So we go back and adjust that. We created departments. We created a tent. Within a day, we were able to generate DEPs, which is departments and everything else that needs to get flushed out, including lab orders, medications, physicians, nurses, access, security, you name it. It's all worked out within a matter of hours. So, and by the way, we've become very good at it, right? So that is how we are changing the way we operate, not just one-off things out there that we used to manage through governance process. It's very different. And by the way, capital as a financial aspect is also going to change how we do business in the future too. Expecting quick ROI, delivering value where we think there is definite value that we can generate for them, and spending as appropriate. Because governance is also about spending, about how do we manage our operating expense, how do we manage our capital expense, and so on and so forth. In this case, we had to do this as quickly as possible. So there was some leeway from that perspective too.
Very good. All right. I want to get some audience questions in here. First question for Wes. Have clients been demanding touch and go hardware at their homes to cut down login times, and what adjustments had to happen for that?
Yeah, thanks. Great question. No, not really. The tap and go, the hardware piece of the tap and go is really to promote that quick log in, log out at a workstation, a shared clinical workstation. And since most folks are working from home from the same PC that they've always worked from, all you're doing is, they may log in just once a day. And so what we're seeing most people do is instead of using a badge tap, they just log into one sign there if they have it delivered to them. So no, we're not seeing a big uptick on that in the US. Now in the UK, they have something called the spine, which is where a bunch of their applications reside. And to get to that, they have to use a smart card. And we're seeing that the UK folks are sending those home with their remote providers. But in the US, no, not really any demand for that. Funny though, we are getting a lot of demand for the some keyboards, some HSI keyboards that have a key called Santa key that you can press, and it locks down the keyboard, and you can sterilize it, and it it's got software that records when the last time it was cleaned and that kind of stuff. But no, nothing really at home.
Very good. All right, next question. Kathy, let's start with you on this. Can you comment on where you will invest the COVID-19 healthcare assistance funds? Will it be clinical or technology?
That is a great question, and I honestly don't know the answer to that yet, because our systems are undergoing such financial impact for this COVID-19. I mean, our hospitals, we're really at half capacity. We have some furloughed staff. I can't predict what exactly we will do with the money. The fortunate thing is that we had a robust technology plan that we were able to fund with our capital currently. So I don't necessarily think that we'll be using a lot of it for technology.
Chuck?
Yeah, I agree. I think on the technology side, telehealth, there's a certain amount of money geared towards those expenses, and we're certainly going after that. That's limited to $1 million. And then there's some other telehealth pilots that you can apply for that are funded as well. But I think a lot of it is going to go to the losses of the organization. I mean, when you close, our ambulatory is closed, everybody's closed, the electives are closed, big money makers, everybody's going to end the year in a deficit. So I think the money will never make up 100% of those losses, but I think a lot of it will go towards at least alleviating some of that.
Sri?
For us, most of that is going to clinical aspect improvements. As Chuck said, probably the $1 million with the FCC that could get into the tele aspect of it, but is most of it on the clinical side, particularly with the revenue loss piece. That's where the funding will go to.
All right, very good. Next question, will you be submitting grant proposals for the CARES Act telehealth section? If yes, what will your ask be for? Chuck, thoughts on that?
Yeah, absolutely. We're actually going after both. We're still writing the Connected Health one. That's the pilot program, so I'm not sure the cost on that, but the telehealth, we're up to about $600,000 at this point that we're going after for that funding.
Sri?
Definitely we are on the telehealth side, no doubt about it. Of course, the grant is limited to $1 million, so we'll apply for all of it. Obviously, there are several other, from a California perspective, state-based grants and funding mechanisms that we will be subscribing to, especially since we are doing some of the research work as well. We've got Dr. Alpesh Amin, widely quoted chair of internal medicine, who's doing a lot of work around clinical research. So there's definitely opportunity there, but we will be going after as much as we can because of our ambulatory visits, our surgery centers, non-elective surgeries, and all this shut down. So elective surgeries get shut down. You have a lot of capacity you could have used otherwise. So we will be going after all of that stuff.
Kathy?
I agree with both of them. We're going after the full 1 million. We are looking at it across all different platforms. We have a large international presence here that we're going to be asking for telehealth funding for, expanding in our ambulatory section, even to the point of upgrading our telephony solution to be able to support better telemedicine exchanges. So we're going after a full 1 million. and any other grant that we can qualify. We're looking at everything because we really need to help fund some of these solutions that we put in quickly. Now we have to go back and do it correctly.
Well said. Well said. All right. Next question has. Let's go with this one. This would be really for Epic shops, but I want to get Wes's opinion on anything he's heard. How has Epic been able to handle the demand? Have they been able to keep up with the clinical support and technical support demand? Wes, have you heard anything? And then we'll go to, and I think Sri's an Epic shop, and I don't know about Chuck and Kathy, but Wes, you want to jump in first?
Yeah, I think they've done an extraordinary job. Everything moving to telehealth very, very quickly. They integrated with Zoom for consults, and I just read something today that the same type of Zoom integration that they've done, they're also doing with Microsoft Teams. They've stood up some COVID modules within Epic for data analytics. I think Epic's done a tremendous job in response, and I think they're in that go minimum viable product kind of mindset right now as well. I'd be interested to hear what Sri has to say about it being an Epic shop.
Sri?
So it is definitely rewarding when you have an Epic vendor as like a partner. Epic kind of put out initially some of the things that we were struggling with when they saw most of their customers struggling with that process. They stepped up and created a roadmap for their customers on what are the things that we should be looking at, how should we be looking at things. And I don't know if you guys have heard, the Javits Center in New York City is an Epic. Was done through a phenomenal capability there. Same thing with McCormick Place in Chicago. A lot of people, a lot of capabilities were brought to Epic and go from there. The telemedicine aspect of Epic is really something that we believe will be helpful. Epic is putting together a lot of plans to integrate video visits into their modules. I heard that there is a possibility of Epic releasing its own video visit capability. Not that they did not have some integration as well, but this will be helpful for their customers. They've done a lot of work in dashboarding, reporting. Very important thing that we are looking at doing with what the Vice President sent out in terms of a letter for data that needs to be submitted on a daily, weekly basis to the feds. Epic helped us through the process by giving us software updates that we could deploy quickly into the environment. And they have turned around their development machinery very fast, very quick. That I think is really helpful for us as an Epic customer to deliver back to our physicians, our patients, and make sure we've got the right feedback that we can provide back to Epic as well. Kind of a day-to-day call. And the other part is they called us, they talked to us, they understand what our struggles are, and are willing to have the entire organization staff help with some of the challenges that we have. Pulled out all stops to help us. I think that's what you can ask out of an EMR vendor at this time.
Well, that's quite a testimonial. Kathy, are you on Epic? And if not, how's your vendor responded to helping you out?
No, Anthony, we're a Cerner shop, and I have to tell you, they have been absolutely phenomenal. They have been a partner like they have never been before. They are fully engaged with everything that's going on in my organization. They're part of my team. They are releasing updates daily that helps us in the workforce. They are offering us workforce assistance in case we need additional help. They've stepped up and done amazing.
Very good. Very good. Chuck, any thoughts there?
Yeah, we're an Epic shop as well. We use, MyChart, Epic MyChart video visits with Zoom integrated in. Works great. They've been awesome. We get a daily update from them with all the tips and tricks and changes that they've seen other people do. It's a very collaborative group, as you know, with Epic clients. Their dashboarding is amazing because you can share that, like we can share with Hartford Hospital, New Haven and others, and look at, how we're doing with supplies, how we're doing with admissions, and just tracking a lot of this data together, which has been really great and collaborative. So no complaints at all.
Very good. All right, we're going to launch our poll here, which you should see now. And then we'll have Wes guess at the results, which I enjoy. Guess with Wes. Remember that, Wes? That's our new thing. Thus far, the U.S. healthcare system has stood up well to the test that COVID-19 has presented. Agree or disagree? And to battle COVID-19, health systems have made some changes that we've talked about today, such as remote care, that are long overdue and will not be undone when things get back to normal. So is this one of those inflection points in history, as it were, that nothing is really the same as it was before? I think it might be. It's very interesting. So go ahead and answer those, and we will get back to our questions. We have another question from the audience. Has anyone used other types of technology, such as robots, for this pandemic? So anything along the lines of robots, anything like that? Let me start with you, Sri.
Yeah, I've heard about this, and I just want to help folks understand it. There are organizations who had robots in use from a perspective of pulling this together, but robots also need to be disinfected and cleaned and so on and so forth. Success is something that we've been able to get to is to see if we can get a physician in the room or a nurse in the room or somebody else in the room with the ability to do a virtual visit with inpatient situations. I know some organizations are using Teams to do that as a way to, get them on the same iPad and have a real-time consult with the patient. That has definitely improved our ability to service our patients. But I think robots are great, but robots with a lot of all these what you would call medical devices that put in data in there also have to be used at the same time. Definitely robots are something that we will have in our clinics, in our hospitals. We just have to get patients to get more used to working with robots. That's something that we are seeing too. So as an industry, so we'll get there. We just have to figure out how do we get those robots working effectively.
Yeah, maybe that's not one of the go things that you throw it in the room and the MVP. You could picture some comically sad or bad situations with that going wrong. Chuck?
Yeah, no, what I'm seeing the robots, I think will come into play even before from a televisit standpoint. It's on supplies. When you think about the supply chain itself and the hands that need to touch the supplies, which is a problem. And so if you can get robots to do that type of delivery from a non-contact perspective, so the first time that the supply is touched by a human is when it's either put on their face or given to a patient in some way. And I'm hearing a lot of organizations are testing robots in that way, and that seems to make a lot of sense and can be done not in a go, but in faster than dealing with patients.
Kathy?
I'd have to agree with both Siri and Chuck, but to Chuck's point, I think there's a place for it, and it's not one of those that you implement now because it's so needed. It's one of those that you need to put thoughtful considerations to, and we're not really doing much on that robot standpoint in this pandemic.
Yeah.
I mean, robots have been used, Anthony, in the past. I know UCSF has a robot that goes up and down delivering food to patients based on patient requests. And they are sized enough to go through the elevators, go down to the floor, pick up the food, go up the elevator, carry medication as necessary. Definitely useful there. Definitely something that we could, especially in an isolated patient kind of situation, very, very useful. But think about it. They also have to be disinfected. They also have to make sure that they don't become the germ carriers, right?
Mm-hmm.
So
yep.
There is that aspect of it that also people need to understand. Robots are great, but they're also in this case specifically, they also have surfaces that could be germ carriers that really need to be disinfected every time they come out of the room and go back in the room too. So that's where you see a difference. The better thing would be to have something in the hallway and get a pipe in, like for a vent or something like that. I've heard of several organizations do that. That would be more beneficial right now because you don't have to, because otherwise you have to go in and disinfect the pipe back and forth every time you use it. But of course, that also has got its own consequences, right? The amount of vent that's being utilized for one patient may not be the same as the patient next door. Some of those challenges too. In fact, they're talking to some of our folks in New York City as they were walking through that through the process. They had the vents, but they did not have the connectors. So they had 3D printers make connectors for those vents. Something that we would not have done in the healthcare world on our own. But that is, we would have said, well, it's not FDA approved, it's not this, it's not that, but that didn't happen. We got to save lives, so figured out how do we go build our, print our own 3D connectors and go from there. Definitely a lot of new stuff that we've done, which you'd never have done through this otherwise, and a lot of learning from here that might be something that stays on with us for a long, long time.
Very good. Wes, your thoughts on robots? You seem like kind of guy like robots. Huh?
Yeah. What would lead you to say that, Anthony?
I bet you're a Star Trek fan. Come on.
Yeah, I've just anecdotally read stuff about people starting to use the robots, and it's mostly along what Sri and Chuck were saying, and that's in the delivery of supplies or delivery of food. So yeah, that's it. Hey, before we go on, I don't want to lose this thought. Been a great panel. Got a lot of interesting suggestions. We have great customers, Imprivata, that have just been sending us use case after use case on how they've taken Imprivata technology and used it in a different way to help with COVID, the COVID-19 crisis. And if you go to imprivata.com/COVID-19, there's a list of 20 some odd use cases, new and innovative ways that our customers have told us that they're using Imprivata technology. So I want to make our viewers, our listeners aware that resource is out there for you as well.
Excellent. All right, I'm going to do our little guess with Wes on the poll. So before I show the results, what's your guess on the first one? The U.S. healthcare system has stood up well. What do you think? Percentage agree?
I think you're gonna be in the 85 percentile range.
85%. All right, it's a little higher than it is. It's a little higher. We're talking 71%. I'll share that in a minute. Okay. So you're a little high there, but not terrible. Not terrible. And the second question, this is a new normal, and things are not going to go back to the way they were. What's your number there?
Oh, that's in the high 90s. I'd say 95, 97. 97 I'll go with.
98. This man is amazing. Oh. This man is amazing, and he's very special, and we're going to share the results now for this special man.
Very good.
We are running short on time. I want to go around and give everyone a chance for some final thoughts here. Something that Chuck has said a couple times This is an amazing time to be in this space. Let's just not limit it to the provider side. So we got our friend Wes online, and I'm here. So it's an amazing time for me. It's an amazing time for everybody in this space. And sort of nothing is more invigorating than having a real mission, right? It gets everyone focused. It doesn't matter if you're working 15 hours a day. You can be working 8 hours a day and be the most miserable person in the world if you don't feel like it's got meaning. You can work 15 hours a day in today's environment. You feel like you're having an impact. I think Kathy said a number of things like this. So it is an amazing time and a historical time to be here. So I'd like to get everybody's final thoughts. Anything you want to share with your CIO colleagues on the line? I don't know if anyone is feeling a little down, getting a little tired, a little exhausted, maybe doesn't have the support from leadership that they'd like, but just give me some inspirational words there, not too much pressure. Chuck, let's start with you.
Thanks, Anthony. Actually, this is something that Kathy touched on earlier. I think what we're going to see, and this is what really excites me about if there's something positive that's going to come out of COVID from an IT perspective, is that, in a lot of organizations across the country, IT has always been considered just a cost center, tolerated cost center. And, I think there's some blame to go around both sides. If you don't have a well-led IT organization and good processes in place and things like that, that's an issue. But there's also been expectation setting on the other side that is beyond the capabilities of IT. And I just think it's always, and finance views it as spending all the money in the organization. You've heard a lot of those things. And that's been going on for years and years and years. And I'll tell you, that beats up a CIO over time more than anything else. And I think we're past that point. I think what Kathy said earlier, that we're going to see a true partnership between our customer base, our users, and IT. They finally see what we can actually do and also what the benefits are to them. And they just can't live without us. We certainly can't live without them. And so it's a true partnership now going forward. And I'm praying that stays and we don't fall back into kind of the old tolerated cost center mode going forward. I don't think we will, but that to me, if there's any legacy that's left here from an IT perspective, that will be a big one.
Kathy?
I just want to piggyback on to what Chuck said, that use this time to reinvent your IT department. There's never going to be another opportunity for you to change the image, change the structure, change the fixed fear mindset than now. Use it as a positive. What do you want it to be? How do you want it to run? How do you want to engage with your customers? How do you want to engage with leadership? And just do it. I mean, there's never a better time than to change than now.
Excellent, Sri. Oh, go ahead, Kath. Finish. Go ahead.
No, I was going to say I just can't piggyback off of Chuck enough that you're the leader. Make it happen. You have the power.
Excellent, Sri.
My call is to people not in healthcare, but outside healthcare. Not in tech, but outside tech. Get to understand technology. It's not being afraid of healthcare. Healthcare is here going to help get you, your father, mother, brother, daughter, singer, whatever, all close to each other through using technology. So that's one thing. The second thing is get to understand mobile. Live a mobile life more than what you can do than today. Talk to your physician and ask him, why can't you have a virtual visit? And why do you really need to get to an office to see somebody?
Yep.
Get to understand medical devices and figure out how to use medical devices for yourself and for the betterment of people around you.
Great points. Great points. Wes, I'm going to give you the last word.
Yeah, one of the questions we had at the beginning, it said, where are you going to invest your funds? Is it going to be in clinical or IT? And, if you listen to what Chuck and Kathy and Sri to some degree are saying, the answer to that should be yes. Because if you're in healthcare IT, when you're building IT, you are building clinical, and that's the mindset that Chuck and I think Kathy are talking about. Is we don't see them distinctly. It's healthcare IT is clinical, but we are there to support the clinician. We are there so that our clinicians can provide care, and that's what I think we'll see come out of this, is that they're not going to be thought of, are you going to invest in IT or clinical? The people are going to start thinking, when I invest in healthcare IT, I am investing in clinical.
Excellent. Well, that's about all we had time for today. What a tremendous panel. I want to thank everyone so much. Regarding continuing education, you can use the final slide in this deck for your CEU needs. You'll get an email when the on-demand recording for this event is ready. If you want to sponsor one of our upcoming events or book a custom event, you could reach out to Nancy Wilcox from our team, and you can go to our website to register for those upcoming events. So with that, I want to thank our amazing, tremendous panel, Kathy Ross, Chuck Podesta, Sri Bharadwaj, and Wes Wright. And I want to thank Imprivata for continuing to support our events and bring great education to the CIO community. And I want to thank you, our attendees, for coming. And with that, everybody have a wonderful day. Thank you.
Thank you.